Thank you for the opportunity to present at this IC. So I'll be discussing the definition of keratoconus progression. Now this is a very important aspect because it determines when we normally do cross-linking and how we proceed. So as you can see, these are various different presentations. Cross-linking is a safe and effective treatment as has been proved, but when do we actually need to do cross-linking? So progression is a specter looming in keratoconus and we need to define it properly. So what is the actual definition? Does it involve a change in refraction, pachymetry, a change in your contact lens fitting, indices, change in the Kmax or the K-mean, or change in higher order aberrations, or does it involve every one of these things together? Now, there was a global consensus on keratoconus and ectatic disease. However, this was kind of like an oxymoron because at the end of it, there was no real consensus. They said progression may be a consistent change in at least two of the following parameters, which is steepening of the anterior corneal surface, posterior corneal surface, and thinning or changes in the pachymetric range, rate of change. This was a paper published by Dr. Duncan's group. Now, they showed a very large number of parameters which can be looked at for looking at progression. However, none of these are actually validated. So this also is not a correct definition for keratoconus progression. They also found that the ABCD classification brought in by Dr. Bellin is probably the indice which is the most sensitive to pick up keratoconus progression, which looks at the anterior and posterior radius of curvature and the thinnest pachymetry. And this is just a broad slide showing how the classification is actually made.
We can go back because there's a lot of noise, or not, I'm not saying noise, lot of talk regarding the this ABCD classification because it is.
Yeah, I'm just going back.
Yeah. So if you really look at it, the new people who are using Pentacam, you need to ask in case they are not loaded this to your machine. I'm not sure whether they charge you, but they charge you. They charge for everything now. So Bellin's ABCD classification, there are two things. There's the last one where you need to add you have to write the patient refractive error, the D one, right?
The distance corrected visual acuity.
Yeah, and then there's the PACI and the PRC and ARC, which is already there in the machine. According to many, this is one of the most robust classification because it gets you the change in your radius of curvature as well as the change in thickness. So, but you know, not many papers have been published by anybody else apart from the same group. So more people believe that this works good, then probably this could be an easy way of looking at it.
You also have to be careful in this classification when looking at the distance corrected visual acuity that you look at it in the same way every time. You can't look at a glass and a contact lens the next time because that won't correlate. So that has to be taken care of carefully. So we define progression, as Sir had also mentioned earlier in our paper, as an increase of greater than 0.5 diopters at 2 or more keratometric values in the steep meridian between two sagittal curvature maps about 6 months apart, along with or a decrease in corneal thickness of greater than 10% at the thinnest point between two pachymetry maps on the pentacam in the last 6 months. So I'm just going to put up a few examples and we need to see whether this is actually progression. So if I can just ask in the audience, would you consider this as a progressive keratoconus and would you do a cross-linking for in this particular map, looking at it, the comparison map? So any answers from the audience? So Vishal says no, and that's the correct answer, basically because it assesses the repeatability. This scan is taken on the same date. It's 2 scans on the same date, 5 minutes apart. So basically, you have to be careful of the repeatability of a machine when you're talking about progression as well. So we published this paper in IOVS looking at the repeatability and agreement of 3 Scheimpflug-based imaging systems. What we found was that haze post-cross-linking also plays an important role in determining whether there's progression or not. So if you do have a significant amount of haze, it's very difficult to comment on progression in these cases. As you can see here, there's a minimal amount of haze on the slit lamp. However, when you look at this on a densitometry map in the pentacam again and see it 5 months apart, there's a significant increase in the amount of haze. So in these kind of cases, it's kind of difficult to comment on progression, whether it's actually happening or not. Now again, another example, is this actually progression or is it not? I'm hiding a certain amount of the data in this slide. So again, in this was taken 3 months apart. Now 3 months after cross-linking, again where haze is still playing a role, it might be difficult to comment on progression. So again, you should wait, as Dr. Rohit had also illustrated, at least a year or year and a half before commenting on progression. Now, when commenting on comparison of two maps, we also need to take into account the best fit sphere that we are actually using for the comparison, as is highlighted by the two circles here. So this was a map done in 2015, a pentacam scan done for this patient. In 2016, when the patient came back, there was a change. However, there was also a change in the best fit sphere in this patient. Now, when you're comparing across two different values of best fit sphere, again, it's not the best way to compare because you will not get an accurate representation. So what you do is change the best fit sphere for comparison, as we did over here. And then you see the comparison map. It shows an increase in the steepness in the elevation in both the front and the back. Now, this is progression. I mean, I'm not showing you exactly the dates that these maps were taken at, but take my word for it, this is actually progression in these patients. So what next? Now, there are high risk factors for progression that have already been illustrated. One is age, family history, eye rubbing, gender, allergic eye disease. All these things can, and Vishal already illustrated that, the 5-point nomogram, how we give high risk factor scoring as well. So modifiable risk factors should be taken care of before going ahead with the cross-linking. First, you have to tackle things like eye rubbing. Tell the patient to avoid eye rubbing, tell him to stop sleeping on a particular side, try to tell him to sleep straight or on the other side. For inflammation, topical steroids and antihistaminic eye drops can be used. Topical cyclosporin has been illustrated earlier, and even tacrolimus recently has got into vogue. Along with that, look at serum IgE levels, an immunological opinion, a patch test can be done, and then according to that, the treatment can be tailor-made for these patients. Now, this was another paper that was published, a couple of cases where the IgE levels were raised. Basically, these two patients were allergic to sunflower oil and sheep wool, and that was actually causing the progression of the keratoconus. So, looking at progression after cross-linking, you have to take into account, like I mentioned, the repeatability of the machine, the haze, ensure that there are good quality scans, look for haze before commenting on progression, wait for at least a year, better to wait for about 2 years, because remodeling and wound healing can occur in that amount of time. If there still is progression, control your risk factors. If that helps and makes it stable, you can still defer cross-linking. However, if despite that there's progression, then you can go ahead and repeat your cross-linking after a year and a half or 2 years. So just a case to illustrate the same, a 24-year-old lady with a history of cross-linking done elsewhere came with a progressive diminution of vision and a change in refraction. She had a history of ocular allergy and eye rubbing, but was also planning pregnancy in the near future. These are her comparative maps between the 6 and the 12 months. You can see that there is a change. There's a change in the elevation as well. Increase in steep K and posterior elevation, change in the refraction, a good quality scan overall. So this was showing us a progression. What we did was first to advise her to control the ocular allergy and eye rubbing. Because she was planning pregnancy, we also wanted to defer the KXL till she finished this, and then after that we were planning the cross-linking. So for progression, what is at fault? It's multifactorial. We have to broaden our outlook and look at systemic factors that also may be influencing progression. The next step would be predicting progressive keratoconus and markers to specifically treat certain factors which can be targeted for preventing progression. Thank you.